Assalamu alaikum and good morning. First of all, I would like to thank organizers um, of the Brain and Biomedicine Conference, IBRO, IBBC, for inviting me to their platform, which is supported by many prestigious organizations, including PASPA, Pakistan Society of Basic and Applied Neurosciences. We developed PASPAN in 2007 at the Panjwani Center for Molecular Medicine and Drug Research at ICCBS, University of Karachi, and affiliated with IBRO, International Brain Research Organization. At that time, I served as the Pioneer Secretary General of PASPAN with Dr. Athar Inam as President and Dr. Suhail Qureshi as the Treasurer of the Society. I affiliated PASPAN with IBRO in 2009, and since then I've been coordinating between PASPAN and International Brain Research Organization. Okay. My name is Kaneez Fatima Shad, and I'm a professor of neuroscience at present affiliated with the School of Life Sciences, University of Sydney, Australia. Every 3 seconds, someone in the world develops dementia. 700 million people is suffering from deafness worldwide. So international statistics shows that almost 50 million people worldwide are suffering from dementia at present, which is expected to be 131.5 million people by 2050. It's a very scary statistic. So I just want, in this slide, we are looking at what is dementia. Dementia is not a disease, but a group of many symptoms suggesting the presence of brain disorder. As you can see, there are many symptoms, including difficulty communicating thoughts and all these sort of things. So you can go through it by yourself. Okay. Now, I just want to tell you that there is a direct relationship between deafness and dementia. So as you can see in this slide that, sorry about my throat, likelihood of dementia increases with the degree of deafness. Okay, so these are the reasons for hearing loss. With the external ear, if there is a hearing loss due to the external ear, it's due to trauma or wax. In the middle ear, due to trauma and fluid. In the inner ear, trauma infection and Meniere's disease. And auditory pathway, if it is affected, is due to viral infection and tumor. Deafness leads to dementia, and you can see the similarities. You can see the depression, anxiety, and disorientation in Alzheimer's, and you can see the similar sort of symptoms in untreated hearing loss. And all these rest of the things like reduced language comprehension, speech comprehension, sorry, and impaired short-term memory and cognitive things. So there is a lot of similarities, as you can see in this slide. Now, the brain of a deaf person may appear smaller compared to that of a hearing person due to phenomena known as auditory deprivation. Auditory deprivation refers to the lack of auditory stimulation that occurs when a person is deaf or has severe hearing loss. When auditory input is absent or significantly reduced, as in the case of deafness, these regions may not develop fully or may undergo structural changes over time. That's why they look a bit different and smaller as compared to the normal hearing person. So in the next slide, we are going to look at the similarities of the deafness and normal hearing person. And now we are looking at these Alzheimer's disease and normal healthy brain. You can see clearly the differences. And as you know, the Alzheimer's disease is a neurodegenerative disorder characterized by the progressive loss of cognitive function, memory impairment, and changes in behavior. So the progressive neuronal loss and degeneration associated with Alzheimer's disease result in a decrease in brain volume and overall brain size. You can see the differences over here in the regions which are affected by the differences in this slide. In our next slide, we are trying to find out the different techniques to fill the gap to diagnose accurate diagnosis of Alzheimer's disease. So diagnostic accuracy of Alzheimer's disease dementia involves a multifaceted approach that combines advances in technology, improvement, and cutting-edge diagnostic criteria, and enhanced collaboration among healthcare professionals. So these are the things which we have to combine together to fill the gap for early diagnosis and for controlling the progression of Alzheimer's disease. In our next slide, we are going to talk about the methods. The first method which we used is MRS, that is magnetic resonance spectroscopy, for looking at the imaging the inferior colliculi. Inferior colliculi is the nuclei in the brain which is responsible for hearing, and to measure the ratio of neuronal axonal degenerated markers which we observed from the inferior colliculi, and the markers were N-acetyl aspartate, NAA, and the glial marker is myoinositol, MI. So these ratios are we calculated respect to the creatine. So we saw MMSE, mini mental examination, was employed to assess the cognitive differences between the normal and mild cognitive state. But in the following slides, you will see that the biochemical changes already occur before it shows into our psychological behavioral test and all the other diagnostic tools we applied. So in this slide, we are examining the values and peaks of neurodegeneration markers using magnetic resonance spectroscopy. In this over here, you're looking at the peaks, and you can say the different values of NAA and MI, and these are the tables which indicate that the values are changing with the time. In this slide, we are measuring, we are analyzing actually event-related potentials using electroencephalography. Why we are doing the involves in this to study the electrical activity of the brain in response to specific stimuli. So this is an electrical activity, and the EEG is a very less expensive instrument which can be easily used everywhere, and as compared to MRS or MRI. So we are trying to find out if we can have a substitute cheaper option for the early diagnosis of Alzheimer's disease. So overall, the analysis of ERP using EEG provides valuable insights into temporal dynamics of brain function and is widely used in cognitive neuroscience, clinical research, and applied fields such as neuropsychology and human-computer interaction. Excuse me. So I'm sorry about it. Just today my throat is not good. Okay. In the next slide, we are looking at. In the next slide, we are looking at the relationship between brainstem auditory evoked potential and event-related potentials, that is BAP and ERP, and it lies their respective roles in measuring different aspects of auditory processing in brain. So BAP represents the early stages of auditory processing, starting from the auditory nerve and traveling through the brainstem nuclei. Whereas ERPs, on the other hand, capture the cortical processing of auditory stimuli occurring beyond the brainstem. So, so BAP is the brainstem, and ERP is cortical region. Okay. Now, in this slide, we're just trying to define voxel and ROI. Voxel and ROI are terms commonly used in the field of neuroimaging, particularly in techniques like MRI or fMRI or MRS. So as you can see over here, voxel a value on a regular grid in three-dimensional space, in this case placed in a specific region of the brain called inferior colliculi. Whereas ROI is the region of interest, and a specific anatomical or functional area within the brain that is selected for detailed analysis. In our case, it is inferior colliculi. Okay. In our next slide, we are looking at the MRS of IC. So I'm sorry, magnetic resonance spectrophotometry of inferior colliculi. As you can see over here, there is an increase of MI and a decrease of NAA ratio with respect to creatinine. This means that the biochemical changes occurs prior to the structural changes, which in turn leads to the behavioral changes. So, so these readings are from brainstem. So by the time it reaches cortical things, all the things are more obvious, and you can see in the structure as well as in the behavior. So if we measure why we did this project, we want to we want to find out the predictive biomarkers of Alzheimer's disease long time back, a long time before its onset. So if we are measuring these values in the brainstem of the patient, who looks very, very normal, and then just be careful and make sure that you will progress cautiously for the next steps. Okay, so maybe it can lead to Alzheimer's disease. So as you can see over here, the same person, we look at MRI and we cannot see any atrophy in the medial temporal lobe using MRI. And but when we use EEG measuring for the measurement of BAP, and we can see a substantial reduction in the electrical peak amplitude and an increase in the time between two peaks. So indicating that biochemical changes followed by electrical changes, and of course all these occurs prior to the structural changes and behavioral changes. Now for this is like a sort of a summary of all the techniques we used for this project. So magnetic resonance was utilized to observe the atrophy of medial temporal lobe. MRS, magnetic resonance spectroscopy, used for neuronal and glial degeneration ratios, MI and NIA, and then we used EEG for the spectral power to evaluate brainstem auditory evoked potentials and event related potentials. So in this slide of MRS, MRI, and EEG, we can see the sequence of neurodegeneration as biochemical changes leading to the electrical, followed by the structural changes, and hence behavioral deviations from normal is going to be expected for this person in future. In this It is concluded, our project, that the functional anomalies are presented prior to the structural abnormalities, and monitoring the activities of the auditory sensory neurons will enhance the accuracy of diagnosis of Alzheimer's disease and possibly could be stopped or prevented. I would like to acknowledge the support of Government of Brunei Darussalam and CHT project grant from UTS Australia. Here is a list of a few references published in international journals as a result of this project. Thank you for listening. Now it's time for questions. And because I'm not